Dear Chairman, dear Banshee, Banshee is always a strong leader in diabetes care for me. I think I do a lot of things, but if I come to India and I'm sitting next to Banshee, then I get the feeling that I'm a very lazy person. So Banshee, thank you very much for your activities in the fight against diabetes, because this is the reason why we are here. We are sitting here, we are discussing because we have a passion to fight against diabetes. And there are aspects which are challenging, and this is what I would like to go through with you in the next few minutes, but also to highlight what the International Diabetes Federation is ready to do, is planning to do, and where I'm inviting all of you to become part of a global community of people passionate to change the life of people living with diabetes. About myself, it just was said, and I must say, standing here for the Lawrence Lecture, the man who founded 75 years ago in Holland, in the Netherlands, the International Diabetes Federation, a name often is forgotten, but he is the founder, he is the frontier in developing a large organization, a roof organization of currently 242 member organizations. In a few weeks, nearly 250 member organizations in the world, covering more than 70% of the diabetes initiatives and organizations worldwide. It's the largest NGO in the world. Unfortunately, not the richest NGO, but the largest NGO. And this is a big, big chance if we take the slogan on the red shirt, fight against diabetes, that we translate this power of this large organization into a successful fight against diabetes. And there was a WCBD meeting in Mumbai a few weeks ago, and they had a picture with a horse and a man on the horse and say, warrior against diabetes. And this is how I see my work and the work of all of us to become a warrior against diabetes. Situation is challenging, already mentioned, and the WHO has released 830 million people living with diabetes, actually 2 years ago. So they released it a few weeks ago, but the data are from 2022. So there's a big number. There's a discussion, is this number right? I think it doesn't matter in the moment. It's a call for action to become a warrior against diabetes because it's needed. There is a big burden related to diabetes worldwide. And where is this burden? Here in the environment, here in the region, in low and very low income countries. So if we start thinking and say, okay, we have our role models, we have our strategies from the ADA, ASD, from the rich countries, they may not work in this environment. And we have to think out of the box to find the right strategy to combat against diabetes in this environment. And being the president of IDF, I have the chance to visit many different diabetes clinics in the world and discuss with the people. These are examples from Africa and from Madagascar. These are examples here, which is the opposite, meeting the president of one country, in Mauritius in this case. And many of these people are very passionate, especially talking to the president of Mauritius was very cool, because there was suddenly someone who said, okay, I understand the burden of diabetes in my country. 1.2 million people, 200,000 people living with diabetes. And now the big difference comes, a totally free healthcare system. So the opportunity to translate evidence-based strategy into practical diabetes prevention, diabetes remission, diabetes care, it's maybe higher in this environment, but if we work together, we might be able to develop role models from the International Diabetes Federation, which can be translated into global care. But if I said I have the chance to meet people, it's not the presidents to meet, it's you to meet. It's the people doing diabetes care, the people being on the last mile of diabetes care. This is what is passionate. This is what is teaching me how we should go ahead in reshaping the quality of diabetes care. And these photos are made all in the last few days, traveling in Africa, in the islands, and then coming here to India. Meeting you is what makes the face of the International Diabetes Federation. As I mentioned, it's a challenge, and we have to understand, we are scientists, we are physicians, we propose evidence-based care. We have to understand determinants, and one determinant is air pollution. If you are looking out of the hotel here in Mumbai, and I always hear it's even worse in Delhi, Yeah, air pollution is becoming a health determinant. And we might say air pollution and diabetes is far away from each other. This slide shows you the conjunction between air pollution and the risk of getting type 2 diabetes. If you find medium-sized particles in the air and you breathe, you find these particles about 2 weeks later in your insulin-producing beta cell. So, for example, imagine a nice German diesel car, and you take a deep breath. The diesel particles you find 2 weeks later in your insulin-producing beta cell. In cell culture, this impairs insulin secretion. We don't fully understand what it does with patients, but it's becoming a relevant future health determinant. But if you ask me what is the main determinant of the increase in prevalence of diabetes worldwide, it's this. And it's this nice, lekker dishes we always consume. We had yesterday in the evening, we have every day. Maybe not as worse as is shown here, but if you are honest, I ordered a breakfast today in the morning to the hotel room. We got the big plate of fried sweets. And we even didn't order them. So this is part of the lifestyle. If you fry carbs at a temperature of above 130 degrees Celsius, you build bonds between fat and glucose, which our body cannot metabolize, and they are getting stored in the liver. So our eating habit makes you becoming a risk of type 2 diabetes. And this is part of the problem why in India the onset of the disease is very young, is at the slim, like Banshi always said, a slim fat person getting diabetes. And where is the slim fat coming from? A large proportion is the fat in the liver and in the pancreas, and this is part of the diabetes problem. And that's why we are dying. And most of the common risk factors, and remember Dr. Mohan yesterday, the A, B, C, and then maybe D rule in preventing diabetes, these risk factors are related to premature death, and the light yellow risk factors are related to climate and temperature. So this is becoming one of the strategies of the International Diabetes Federation to combat with this. And the driver might be premature death for some countries. I always say prevention, and after prevention comes prevention, and then comes prevention again. This is where my heart is beating for. Prevention, because we know enough to prevent diabetes. We know it from a societal level. We know it from the political level, from the medical level, from the evidence-based level. Why are we not doing it? If someone would come and say, would you like to have a high blood pressure because you might get a stroke? So we are totally agreeing to treat blood pressure as early as possible to a normal range to prevent stroke. Why are we accepting hyperglycemia and not treating early hyperglycemia or early risk factors in the same content? It's a different concept for us, for the same physician, same based evidence. And it's sometimes easy to do something against it. Walking 10,000 steps early on prevents diabetes from developing, as many other chronic diseases. And if you have diabetes, it lowers postprandial blood sugar twice as much as 1,000 milligrams of metformin are doing. This is cool. This is successful strategy against diabetes. We are built to walk 36 to 39,000 steps a day. This is what we are walking per day. We are a lazy species. We are a very lazy species. We are not using the power anymore. And asking the question the other way around, this is the number of hours we are physically inactive per day. Again, we are a lazy species, and we should not wonder if we are so lazy and getting sick by this. But we can change this. This is an example of CGM of someone who's very insulin sensitive. It's a young woman, she needs 1% of the insulin to regulate blood sugar. She's totally healthy, has no risk of getting diabetes, and here's her father. The father is actually having a better A1C than the daughter, but look at the curve. It's going up and down and up and down in the normal range. It's even not a high normal range, but the father is very insulin resistant. He needs about 80% of the insulin to regulate blood sugar, and that makes him in about 3 to 5 years getting diabetes. So the consequence for us today is if you have two people with the same A1C and one has mild fluctuation of glucose, the other one has big fluctuation of glucose, The one with a big fluctuation may die because of a stroke and a heart attack. The one with a mild fluctuation may not even need an intensive treatment. This is an interesting approach if we would be able to identify the fluctuations, and we need sensors for it. We need cheap sensors, widely available sensors for it, and we need to agree that we can use the data also for diagnostic purposes. There's still a way to go, but I think we will at the end be successful. Today we don't find the people, but if we have sensors for less than $1, we will be able to change the life of people living with diabetes by reducing fluctuation and optimizing, individualizing the treatment for our patient. Next to the visceral fat, which is the predominant determinant until about 5 years ago, now the hepatic fat is coming into the game. And the hepatic fat, we should rephrase our understanding in the determinants of diabetes development. Probably 9 out of 10 points in the risk development is hepatic fat, and 1 is the visceral fat. The visceral fat is much better understood because we know that the visceral fat produces more than 800 known peptide hormones, and they are getting us depression, diabetes, hypertension, metabolic syndrome. But the hepatic fat is killing us. So the pure presence of the hepatic fat makes you becoming a non-responder to physical activity. And I just mentioned how important is physical activity. The diabetology everyone has inherited in his body is physical activity. And everyone can use it. There's no overdosing of physical activity, but the hepatic fat destroys this. And where is the hepatic fat coming from? From the Indian lifestyle. Not 100%, but most of it. And this is something we should tackle. This is something we should address. Sometimes it's enough changing frying from oil to an air fryer, because suddenly you remove the fat out of the process. Here diabetes starts, here we diagnose diabetes. So honestly, we come far too late. Yeah? If I'm talking about prevention, and talk to physicians, the ability of preventing diabetes in the clinic is far too late. So we have to rethink whether we can tackle this red paradigm before the pathophysiology of development of risk, public health, health promotion, diabetes remission strategies as International Diabetes Federation to become the barrier against diabetes. This means we have to understand the interplay between these two fat compartments, and I think the solution or one big solution could be in there, and this is shown by Taylor. In animal studies, a little bit also in humans, if you have fat in the liver and you also have it in the pancreas, and this destroys beta cell secretion. If you remove the fat out of the pancreas or out of the liver, you also remove it out of the pancreas, and this may restore beta cell function. And what is the restorage of beta cell function? It's diabetes remission. This is what we want. I will not say cure of diabetes, but diabetes remission is our ultimate goal in what we are doing. And what is the way to get the liver fat away? It means we need glucagon. We need a release of glucagon first to break down glycogen, and after certain days then to break down, instead of protein, to break down fat to make ketones out of it, because the glucagon is a fascinating hormone, the stepbrother of insulin. Glucagon is present in the liver and the pancreas. So how to activate glucagon over a period of days to free fat from the pancreas and the liver? And the answer is fasting. If you don't eat any kilocalorie, if you don't eat any energy, then after 4 days, glucagon starts breaking down fat to ketones and is doing it mainly in the pancreas and the liver. This is, next to physical activity, our natural diabetologist in our body by not eating, fasting, and I think this will, or this kind of fasting can lead in a substantial proportion of our type 2 diabetes patient to a remission of diabetes. But we also have to understand where this is coming from. And normally I like to ask who likes to drink Coca-Cola. Some hands go up, then I ask for Diet Coke, maybe some more hands go up. Here you see 380,000 patient years on this slide, and it's analyzed if you have one soft drink per day over the period of 1 year, what it does with your diabetes risk. And if you drink water, it's not increasing diabetes risk. Orange juice and Coca-Cola, about 40%, but the Diet Coke or Coca-Cola Light or Zero, is doing 60%. How can this be? How can the Coke without sugar make more diabetes than the Coke with sugar? And the answer are artificial sweetener. And the artificial sweetener change our microbiome. Now we could say, I don't care about my microbiome. Why is this dangerous? And the answer is exactly the same like for the fried carbs, because the change of microbiome due to artificial sweetener allows bacteria to invade our gut. And this bacteria produce fatty acids, build a bond to glucose, and it's the same what you get if you fry carbs. And this fatty acids and glucose is basically the stool of the bacteria of this changed microbiome. They are in our gut, we incorporate them and store them in the liver, and this makes us becoming non-responder for physical activity. But let's focus how to change this. I mentioned already fasting is one strategy, but it always needs motivation, motivation, motivation. And we are in an ideal situation that the technology development enables us to become closer to our patient. And this is digitalization, smart health, mobile health, and also using AI in the field. Here you see gray, how our anti-diabetic agent lower A1C, green lifestyle, and blue, how digital tools are lowering A1C. And you might say, no, that's impossible. How can a young digital tool, which normally is a smartphone-based app, lower A1C? It's not a drug. It's impossible. No, it is not. We are in the pocket of our patient. We never have been so close to our patient than being in their pocket. If we now stop and say, okay, we do diabetology as we have done it in the last 50 years, but we do it out of the pocket of the patient, we might fail. Being in the pocket of the patient means being on the hub of decision-making of the individual. Every one of us is taking 1,800 decisions a day. 450 are related to lifestyle. Now imagine, in the right moment, with the right motivational strategy, with the right content, impulses are set to influence only 10 out of the 450 lifestyle-related decisions per day, but doing it over the period of 1 year, this might change our lifestyle and can be translated to 10 kilogram of weight reduction. This is cool. This is lifestyle change out of the pocket of the patient, and I think modern diabetology in the future might look like this. And we should not fear this. Here's an example of a licensed diabetes therapeutic app in Germany using AI to help the patient to change the lifestyle. Another one was in Germany also licensed and is also addressing Indian food in Germany. So you make a photo, it's qualified and quantified, and the patient is not getting blamed for what he is eating, but the information is used to shape the impulses to help them to have a better next meal. Using the sensors and app-based technology and using the shape of the sensor curve to help the patient to change eating habits to reduce glycemia and to prevent diabetes. And here, Swedish development. This is diabetology out of the pocket of the patient. So the curve of the sensor of the individual is immediately compared to a swarm of 1,000 patients, and they track their daily behavior. So based on the curve, the daily behavior is analyzed, and this app makes clear recommendation. Today at 6:35, you inject 22 units of long-acting insulin. And now we get a shock and say, no, we don't want, because we are the diabetologist. Yeah, this is right. The patient who can come to us may not need such an app. But think about Rwanda, 380,000 people living with diabetes and one diabetologist, and a digital infrastructure which is better than Europe. So there are opportunities, if we look from the global scale, where this might be an opportunity to a solution for people living with diabetes, and this is artificial intelligence. And artificial intelligence in our hand, I think, is a clear advantage for our patient. But we have to keep it in our hand. And in India, Madhu is a development here from Doctors AI, from physicians in India who developed an AI-based tool to reach this. And this is cool. This is good because it helps the patient immediately. And I'm discussing this with Google and also Meta. And Google tells me, Peter, 85% of the health content on the internet is wrong. And now imagine generative AI. So that means AI learning from all sources accessible, learns from the 85% wrong content. There is a kind of danger in it. So we are in the moment experiencing a hype of AI, but it's dropping already a little bit because of the false content. And who can solve this? It's us. It's us as physicians to keep the AI tools in our hand to train AI to the sake of our patient, to really make it an advantage to our patient. Coming back to the fasting again, eating less is healthy. We all know, maybe eating nothing for a certain period is even more healthy. And you reset the microbiome, you reset your liver fat. And this is clearly a very fast gain of health to anyone who wants to do it for himself. I always recommend to do it as physician yourself first and then recommend to the patient, but it's an advantage. An AGP from a patient after fasting, a type 2 diabetes patient, look at the bold printed line. This looks like the curve of the lady I showed you at the beginning, a flat glucose curve. MRI spectroscopy from the liver, you see the cloudy stuff in the liver, this is fat in the liver, and this is after the fasting, and the liver is free of fat. This is cool, this is easy. It's expensive to diagnose still, but it's very cheap to do the fasting. It even doesn't cost money to buy food. I installed a group which works on fasting and type 2 diabetes, more than 180 experts worldwide. Some of them are very excellent scientists. Some of them are very good practitioners in the field. And we assess 19 different styles of fasting for type 2 diabetes prevention and care, and the guideline will be released in about 1 year from now. These are the different kind of fasting styles, some of the names on it, and these are the 2 people leading this group. It's led by the MENA region in IDF. And I'm very, very thankful to all these people doing this passionate work. For me, as president of IDF, means serving IDF, serving the need of people with diabetes, because I truly believe that everyone should have the same access and same availability of diabetes care. And there's a big gap, there's this big lack of reaching this. So there's still a huge amount of work to be done ahead of us. And it's not IDF or the office can do this. This is us. We as community of people who are passionate to improve quality of diabetes care can do this. And I have 3 goals. One goal is to be in the brain of every health politician in the world. There are only 7,800 parliamentarians in the world. The number is not so big. The second one is being in the pocket of every patient. Third one, in the heart of every healthcare professional. So in the heart of every one of you. How to reach this? First one is a global diabetes index. Once a year, we will ask patients and physicians in every country in the world, more than 100,000, about their perception of the quality of diabetes care. And then we translate this into an index, and we've up to 100. And suddenly you make the quality of diabetes care comparable between Kerala and Indiana in the United States. So why doing this? Because imagine your Minister of Health, and he might see the neighboring country scores 5% better than your country. Maybe some people ask, we should do something to improve quality of diabetes care. Maybe he's ignoring it, but next year we do it again, and the neighbor might have increased by 2%. And then the people are, why have you not done anything last year? Second step is being in the pocket of every patient. You can imagine IDF being in the pocket of every patient with a freely accessible diabetes education program. So bringing diabetes education and qualified evidence-based diabetes education to the patient in Congo who might have a smartphone but not enough money to go to the pharmacist and the physician. And this might change the world for those people because suddenly they get to know something about their diabetes. And finally, being in the heart of every healthcare professional is the IDF Fellowship Program. We just started, and I strongly invite you to become fellow of the International Diabetes Federation. Like yesterday, the Fellowship of Diabetes India, become fellow of the international community of people who are passionate to improve quality of diabetes care worldwide. Let's stimulate the International Diabetes Federation with your experience, with your style of doing diabetes prevention and care, and develop success models which we might implement in other countries then as well. There's also a honorary fellowship program and a senior fellowship program. Many of you, this would be applicable to. And this is our way as International Diabetes Federation to honor your achievement, your work, your experience, because this is extremely valuable for diabetes care worldwide. So finally, The application for the fellowship program is open now. If you have your smartphone in your hand, this is a QR code to directly go to the fellowship program. And there are more QR codes. I invite you to come to the International Diabetes Federation World Congress of Diabetes in Bangkok in a few weeks from now. Until tomorrow, you still can submit an abstract to the Congress. Another QR code about social media channels to follow. And the most important one is this one. This is my WhatsApp channel as president of IDF. All the information, all the activities will be released throughout this channel. There are a lot of faces of people living with diabetes here on Earth. Let's work together. Let's be passionate and committed to a high quality of diabetes care. Let's think out of the box to improve quality of diabetes care and put a smile on the faces of people living with diabetes worldwide. And this cooperation might help then finally our patient to walk away from diabetes. Thank you very much.